Would you like to know what to do about air quality, disinfection, and aerosolization? How to best protect your patients, your team, and yourself? That's exactly why we're here today, and we're starting right now.
And now, Amazon #1 best-selling author, Dr. Tom, the Gems Guy, Orent.
Dr. Bill Hunsinger is a wet-fingered dentist who brings with him his team of experts today, including an architect, a senior building design and project engineer, an IT specialist with a background in EPA and FDA dental product distribution. Bill and his team are my guests today. Bill, thank you so much for joining us. How are you doing today?
I'm doing fantastic, Tom. How about you?
I'm doing great. Thank you so much for asking.
Hey, Tom, it is great to be here. I just wanted to also introduce a couple of people we have with us here today. We have Hantron, our senior designer for our dental offices. We have Jim Jarvis, who's our lead architect. And we also have Mark Bly, who's an expert on sanitization of dental offices. And he actually does quite a bit of IT work with us too. So that's the group that's here to talk with us today.
Awesome. Let me jump right in with my first question. My members, mostly general dentists, also have quite a few specialists, but the question is, dentists are overwhelmed right now, thinking about what's going to happen when they go back into practice, what are all the changes that they're facing. So my first question to you is really, what do you see as the new normal? What's the profession facing? How and what kind of even intermediate things should we be doing to address safety for patients, for team members, and for ourselves?
Well, Tom, I hate to date myself, but I actually, when I came out of dental school, I did not wear gloves and I did not wear a set of scrubs, and I only wore glasses to see. They were not to protect my eyes. And what we're going to be seeing with this COVID-19 is changes that happen like that. Changes like we had with HIV. So COVID-19 is not going to go away. We're going to have some other types of viruses. So we're going to have to deal with it. And staff safety and patient safety are two high issues. So I came back from actually a SPEAR course on March 13th or 12th and started reading about this. And I immediately decided to call my friends here and say, guys, what can we do quickly and what can we do long-term to improve the safety of our offices? And some of those things are short-term. You can put sneeze guards up. You can do social distancing. There's all kinds of things like that. But also what we're looking at is, do we need to change the way we clean the office, how we cover things, and do we need to change the way the office is set up, which is a design issue, which Han and Jim handle. And we also got a lot of engineering issues, which Han and Jim will talk about. So there's quite a few things that have actually kept me up over the last few weeks thinking about it. And since I'm a dentist, I decided to consult these guys, and that's why they're here today to talk with us.
Can you share with us, what is HJT's research? What have you guys discovered about how to best implement the findings to minimize the spread and the effect of the pathogens?
Well, Tom, let me talk about, there's 5 main things that we've really looked at. And some of the things we're going to cover in the presentation are right here. And a lot of it is indoor air quality, surface contamination, building design, patient flow, and interaction. So that is some of the stuff we're going to cover. And each one of these guys is going to be talking about it. Now, what I wanted to do is, Tom, this goes back to when we were started out in dentistry. There used to be a window right there. We used to knock on the window and we'd open it up and say, what the heck do you want? Well, with all of the consulting and all the stuff that I spent time with you as being a welcoming office and letting people in and smiling, giving them office tours, we're not going to be able to do this anymore. So the first thing that happens now, and what we're being instructed to do is let's take your temperature. Let's see if you're well or not. Now, there's a lot of research going on right now about actually testing people in the office. In Ohio, we're not allowed to do that right now. But with one of these instant tests, we may be able to actually check and see if either staff or patients are active with the virus. So the other thing that we're talking about is the 6 feet social distancing in our offices. And as you can see, I actually put these little dividers up to try to keep people separate. We have not had anybody in yet, because we're only taking care of emergencies. The other thing is now we're going to have these sneeze guards everywhere. It's going to look like, now Tom, you're old enough to know this, they used to have banks like this, except they had bars, okay? But these are some of the things that can be done temporarily, and these are actually some of the things that we've done in our office, is to try to cut down on the spread of the virus. Now, this is an interesting slide if you took microbiology. I know, Tom, you're a genius at this. I might have been asleep at the Ohio State University. We were more interested in football there. But as you can see, the size of this virus is very small. Now I want to tell you guys something. That Jim found this slide. He loves this kind of stuff because what he's going to be talking about pretty soon is a filter that can get after that little bugger right there, that 0.06. So you can see the sizes. I mean, that big red blood cells there. We got all kinds of good stuff there, but you can see how tiny this little virus is. So what Jim's going to talk about right now is HVAC filters. And if you really want to know about filters, you want to know all about sizes and airflow, this is where you really want to pay attention. So Jim, this is an exciting topic for you. I know you enjoyed looking at it. I'm going to turn this over to you. And in fact, I've already covered this first slide for you. So I'm going to let you go on to the next one, okay?
Thank you, Bill. And you're exactly right. All HVAC systems have filters in them. And obviously they filter out three things. You're dealing with chemical, indoor air pollution deals with chemical, particulates, and biological. Now, obviously we're talking about biological because we're talking about viruses, bacteria, pathogens of those kinds, mold, and allergens. So next, coronavirus is 0.06 to 0.14 in size, so it's extremely small. It needs what's called a super HEPA filter. It has to be at least a MERV 18 to be able to attempt to filter it. And even that, it has to be going through 2 or 3 cycles before you will actually
so Jim,
get it full.
If I put a MERV 18 in my HVAC system over at Dental Health Associates, what would happen to the airflow in my office?
You can't, because unless your system is designed to take a HEPA filter, it will choke off the airflow, and airflow is an important part of the whole solution. You have to have enough airflow to grab the particulates that are in the air and running through the system and filter.
So the air's got to be turned over so much, correct?
That's right. It's required by code, and it's also required by numerous other 3-letter agencies that mandate these kind of things. So you can't just go switch it out. It's not a simple fix.
So
usually you have to upgrade your equipment.
If you want to know the sizes of how filters work. Jim loves this slide.
Yeah.
He wanted me to particularly point it out to everybody so they could see how the filtration system works. This was a really fun thing. This was something that Jim and I had a pretty long discussion about as we're in the process of remodeling. So Jim, what do you think? Replace or upgrade? What do we do?
Well, obviously you have to look at all particulars. If you own your building, then obviously you can potentially upgrade by replacing your system. If you don't own your building, then you're going to have to deal with a landlord. You may not have this option available to you. So it is something that it's unique to what you are in your particular practice. But upgrading is one way.
What would an upgrade do for us? Would an upgrade at this point, what does it do?
You can put in a higher MERV filter in your system. You have to upsize your equipment to be able to do that.
Okay. So, oh, wow.
Okay. And these show examples of that kind of stuff. And then you might have the ability to integrate a air exchanging system that has to be done correctly. The real interesting part about an air exchanger is you can actually cause more harm with an air exchanger when it comes to spreading the pathogen, unless you do it right.
So Jim, you know how to do that kind of stuff, right? We can work with the contractor and figure that out.
Our engineering team and consultants of experts know exactly how to solve these problems in such a way that you are protecting yourself, your patients, and effectively not causing this thing to spread throughout your building.
Now, what we're going to talk about next, along with this air filtration and airflow system, is these standalone units. Now, Han, I've got one of these ones I bought at Best Buy in my living room. Is that something I can put in my operatory? Is that something that's going to work, or do we need to go a little bit further?
No, you're going to have to go upgrade because the one that you purchased for your home is basically for your home. It take out the particulates and the danders and things like that. It may even reduce odor, but it certainly are not designed to remove pathogens. So what we're talking about is hospital grade type of standalone filtration. You got to remember it is hospital grade. It does a couple of things. It filters out the particulates, it kills the pathogens, and it handles the odors. It was designed for a small space, and then if you need a larger space, then you go to larger units.
So you can see, Han, this is a pretty interesting slide because it shows all the different types of filters and how they're going to work and how we can stop the virus. Now, this is where the rubber hits the road. This is actually something Han got for me here. Han, you were talking to a particular vendor, I believe.
Yes.
And you sent him this floor plan, and what did he come back with here?
Well, we asked him to give us a layout of what we can do, because of course, you have to look at the economic of it as well. So he came back with a proposal that, because the space is, a typical dentist office is divided up into a lot of small compartments. So what it's warned for is, units that handle individual space. So this is typically the minimal. You need to address where the source of your big concern would be your typical treatment rooms, where aerosol and stuff like that are generated. So
right, and aerosols are something we're going to address later, so you want to really pay attention, because this is a system that we're putting together, because what we've looked at is how to upgrade your HVAC and your filters to get better airflow and remove viruses. We've got standalone units throughout the office to get better airflow and reduce the level of viruses. So we've covered two things pretty clearly so far. This particular company has different size units. They've been around for quite a while. They've been used in hospitals. Sports teams have them. If you want to contact me later, I can tell you how much all this will cost.
Bill, how about UV radiation? I hear all about that, but does it eradicate the pathogens? What are your findings on that?
Well, let's let Jim talk about that right now.
Sure.
Thank you. Actually, it's excellent. And you're correct. UV light will, in fact, eradicate the pathogen along with any other biological. It is proven. It's been around for centuries. And the easiest way to install that into a HVAC system is UV lights that are hidden in your ductwork. That light is on constantly, your fan is on constantly, and as the equipment is circulating the air, the pathogen goes by the light and it's destroyed. We can also be used in surface situations. If you apply the light either portably or mounted on a ceiling in an unoccupied space, when you're away at night, turn on the UV light and effectively kill the pathogen throughout the whole space on all the surfaces.
Awesome. One thing that I've seen a huge amount of buzz about is the negative pressure treatment rooms, and I'm watching as closely as I can, and the word on the web seems to be that they're not going to be required, although there may be people who are installing one or two of them. So what are your thoughts on that?
Well, Han, this is your thing, buddy.
Right, yes, Tom, you're right. There's a lot of buzz about the negative air pressure, and so far we have not encountered any agency that mandates this. Mainly negative pressure is talking about containment of infectious airborne pathogens, which is what we're dealing with. How the basic premise of that is that the particular room that's being isolated, the air pressure within that room is less than the surrounding space, so no pathogen within that room can escape. Even when you open the door, all the air from the outside rushes in. So it is a present. I think it can be applied or can be implemented in some facility, but it was meant to be designed for specific rooms, but not the entire buildings. So it's again, it has not been mandated yet. So we're waiting on to see the development, future or upcoming mandates.
Tom, did you see the same thing I saw about Pennsylvania? They put it in and then they took it out, I believe.
Yes, they did. Yeah. Okay, so we're looking at all of the mechanical guidelines and things like that, and we will update our findings and our knowledge and recommendation based on those guidelines.
Okay.
Excellent. What are you guys doing relating to, let's say, building design and especially for facility changes?
Well, Han, you've actually done some of this work, haven't you?
Yes, we have. We look at, besides all the immediate, implementations of, social distancing, sneeze guards, and things of that nature. We look at the entire office and see how the traffic flow can be modified so that the interaction between the incoming and outgoing traffic is minimized. So this slide here basically show the proposed travel pattern for the patient that's coming in and coming out. So the red or the pink indicate the exiting traffic, and the yellow showing the traffic that is coming in and going to the treatment room and then exit out. So we have dedicated in and out path. Also, for the immediate, for existing facility, we look at whether we can compartmentalize the clinical area by installing doors. In this case, we did. We put in a door right there as you're coming in the traffic, and then we also put a door dividing up the corridor and separating the blue area, the clinical, from the public area and the exit area. So those are the immediate, cheap and quick, easy way to do things.
Now we haven't got an estimate on yet. If you guys noticed, that's my office too. So again, there's things we're looking at right now on this.
What I'd like you to do, if you could, is if you could talk about some of the design changes that HCT is looking at for future dental offices. So not just, right now we've talked mostly about, as you say, one of your offices and how you're changing that, but what about future design?
That's a great question there, Tom. We look at, because we had a tendency to touch everything. So a lot of the strategies for future practices will be implement as much no-touch, accessories and doors and things like that. So that way it minimizes transfer of infections. Automatic doors is one of those. Eliminating surfaces in your clinical area, cabinetries and things like that, either minimize it or greatly reduce them. That in terms of material, apparatus. Now, in terms of the layout, we have a little bit more liberty on this one. We actually create define entry point for incoming traffic. So they're taken into the clinical area, and from that point, once they're done, they can exit the exit corridor. We look at the treatment room, particularly the one toward the center. They come in one door and they exit the other door, so they're not mixing the traffic. Okay, so of course it's this is a future practice, so we have a little bit more flexibility in the way we design. So it will take a little bit more room, but the whole practice is compartmentalized or zoned properly, so that you have your public, you have your clinical, and you have your staff, and very little interactions between the traffic.
My question would be for existing offices, because realistically, the vast majority of the viewers in our country and around the world who are watching this, they have an existing office and they're going to need to just make renovations. So what can dentists do right now? What kind of investigations have you been looking into, and what can they look for existing offices?
I like, this is fixes that are relatively inexpensive, and they can do it without having to shut down and things like that, maybe over the weekend. But no touch accessory should be a no-brainer in your facility. Okay, no touch toilet, that makes a lot of sense. Faucet, well, you don't want them to touch that neither. Automatic door operators, you can use, you don't have to touch it with your hand, but you can touch your elbow, like what you typically see in a hospital facility. Doors, the treatment room, there is numerous of tools and accessories that can be used so that you don't literally have to touch the door or many surfaces. So eliminating the opportunity for transfer of bacteria and germ and things of that nature would be greatly.
Yeah, that's like your ADA stuff right there too, Han. The door.
Yes, it's part of it. Sometimes it's part of the ADA requirement, but you can certainly use that strategy for a no-touch type of application.
Okay, so Bill, I want you to do one thing if you would, because many of our viewers may be assuming that when you talk about ADA requirements, we're talking about the American Dental Association, but it's really important that you could differentiate and explain what that is.
You're right. That's a common confusion. When we say when you deal with design, you say ADA is stands for American with Disability Act. Okay, so that is a standard guideline that's usually for accessibility issue, and it's has nothing to do with dental. It's important that you comply with that. The government department that oversees that is the Department of Justice. They have more people. They have bigger muscles to go after people that do not comply with that.
So Bill, how about the reception area? What kind of changes can we expect? And let's say a new patient's coming in, what's their perception or experience for the new patients?
We're definitely going to have to change some of the way we check people in and the way we handle things. We've already showed we're going to look like the bank again. You can see in this very corner of this picture, there's paper charts. That's probably going to go away. We're talking about online scheduling, curbside text confirmations, all sorts of things to where we can maintain a safe area between the staff and the patient at the front desk area. And it's going to be a challenge. And again, we've looked at all of this kind of stuff. But one of the other things that's coming up, Tom, and I'd like for you to give us a few of your thoughts about how patients are going to look at an office now. Because I've been thinking long and hard about it. And since I have you here today, I'd like to ask you a few things about that. So what do you think?
Funny you should ask that question. For our viewers, this was not rehearsed, so this was kind of a left field question. But the reason I say it's a good one is that yesterday I was interviewed by Steve Parker, the Profitable Dentist, and what was planned as a 20-minute interview was an hour and 3/4. And one of the things we talked about is how are the patients going to be perceiving a dentist going back to the office? My view on this, and I have to preface this by saying that I've always considered myself a realistic optimist. Optimist meaning I look at the bright side, I look at the good stuff. I really don't spend much, if any time at all, focused on negative, especially if the negative is something over which I have zero control. So that's helped me a lot throughout my life in business and personally. But when I look at this question, which is how are dental patients going to perceive dentists and dental practices going back in, my answer to Steve when we talked about this yesterday was, it's going to be way harder than we think. So as difficult as we think it is going back, it's going to be worse. You know, one might imagine that, you know, their biggest fear, the patient's biggest fear is the viruses and the bacteria and sterilization and infection control. And while those are all huge, those aren't even, I don't think, it's only my guess, but my forecast is that's going to be eclipsed by them looking at the financial aspects of putting money into dentistry right now, and number two, taking time off from work right now to visit a dentist. So a lot of what we talked about yesterday and what I was working on with him was looking at two words, and if you're writing anything down, I would write down these two words, and that's called patient-centric or patient centricity. We need to put ourselves in the patient's chair and the patient's mind and figure out what is their fear. And yes, it's definitely infection control and everything we've talked about so far, but it's way stronger than that. It has to do with their livelihood, their jobs, their families, and their income. And so patient centricity includes things like, and as an aside, you know me well enough to know that we were doing this 20 years ago. We were open at 7 in the morning. We closed at 10 at night. Now, we didn't do that all in one day. We would go from 7 to 2 on one day. We would go from 3 to 10 on another day. We were open Saturdays. And now I have a couple members, actually several members, who are open on Sundays. And so these are things that we don't want to hear in our profession because we've always had it pretty easy when it comes to the way we schedule. It's not going to work anymore. So that's my short answer to your question, which is patient perception of the whole idea of coming into a dentist is very different. Do I think we'll survive? Yes. Do I think that you can still thrive and really do good for your patients and your team and your family financially? The answer is absolutely, but it's going to take some effort and some really positive thinking on that.
Wow. I hadn't actually thought about that, Tom. That's all. That's great. Those are great answers. That's really something to ponder.
This actually leads me into my next question for you, because now we're talking about the relationship between doctor and patient, and practice and patient, and team and patient. And in the old days, we used to have the consultation room. We would get up from the chair, bring them into the consult room, explain their treatment. How might that be changing today?
Well, we've actually, funny you should say that, we've actually addressed that issue in one of our diagrams here. So I went to Han and Jim and I said, well, what are some of the things we can do? And Jim, you and Han discussed this. What did we decide to do here?
So
Absolutely.
Tom, this is an example of a new design. So we have, we put in 2 dedicated doors, one for the patient, one for the, for the doctor. So they do still sit, at a desk and face to face, and between them is a shield for the sneeze guard. We still have the technologies available so they can see it. So I think from a functional standpoint, it's still intact. This slide here shows an existing. Actually, it's at Bill's office. So the only thing we did is we put in the sneeze guard, so that way, naturally, and then we put in a secondary door to allow Bill to access that treatment room without having to cross traffic with the patient coming in. Okay, so that's how we address that, and everything that had been designed originally for the presentation in the consultation room didn't change. So it's just a matter of changing the traffic and and the sneeze guard.
So Tom, I thought I was going to end up putting this as a storage room at first, when this first came up. So Han presented me with this. I have a question for you, and we're going to talk about it. I have another question. What about this need treatment plan presentation with your treatment coordinator back in the op to do same-day dentistry? What are we going to do with that?
Okay, it's funny you should ask that question, because as you guys were describing the changes that you would propose in future design for consult rooms, I actually did a shift years ago. We had a beautiful consult room. In fact, it doubled as a studio portrait photography room. As you know, I did a lot of very high-end aesthetic and occlusal work. And so when I did smile makeovers, typically we would take before and after photos in our quote-unquote photo studio / consultation room. And in fact, the consult room that I had in my dental practices looked very similar to the studio that I'm standing in right now, with all the different lighting and cameras and everything. And so it was very impressive for patients. However, we stopped using it. Now, we still used it for the photos, so we still brought them in there for before and after photos, so we would get spectacular photos, but we stopped using it as a consult room, and here's why. What I found, and you just brought up the toe-to-toe, knee-to-knee, eye-to-eye, if it is safe enough to be treating a patient in a room that's properly filtered, with us wearing the shields and the gowns and the gloves and the masks and everything else, then I think and that's with high-speed drills going with Cavitrons, if we're still using them, by the way. But the point is, if it's safe enough to treat a patient, then it's going to be safe enough to talk to a patient. So my answer, and this is just one guy's opinion, but my answer to your question is, I would stay right there in the chair and I would sit there and just talk to them about what they need.
Okay, so you would actually have the doctor sit and talk about the treatment and how that's going to go.
I believe that in most cases, now I'm not talking about a complex $50,000 or $80,000 perio-pros case, but in most cases, when you're talking about, say you're doing a recall exam and there's one quadrant of dentistry to do, so you've got inlay, onlay, crown buildup, or you're talking about $3,000, $4,000, $5,000 worth of work. You will find case acceptance is much higher when the doctor, especially in the absence of symptoms, so we're talking about an asymptomatic patient, which is 95% of our patients. So with an asymptomatic patient, I would far prefer that the hygienist, he or she, be the one. And we had 5 hygienists between the 2 practices, and we always used to train the hygiene team on this, that they would go through all of the diagnostic tests and x-rays and photos and using transillumination and using Diagnodent or Canary View or whatever your SoPro Life, whatever your favorite is. They would do all the diagnostics, Then they would actually tell the patient about what they see and what the problems are, and then they would even get into what the potential treatments are. So now I know what some of the viewers are thinking, which is, that's not legal in my state, or if they're in Canada, that's not legal in my province, or if they're in another country, my country doesn't allow that. Well, there's nowhere that allows that. As if you're not a dentist, if you don't have the dental degree, you're not allowed to diagnose or treatment plan. Having said that, I'll start with my disclaimer, which is I'm not an attorney. So you should check with your attorney, whatever state or province or wherever you are in the world, check with your attorney first. But here's what we trained all of our 5 hygienists to say. They would do all the diagnostics, and then before they would give their opinion of what's wrong and then how we might solve that, what they would say was, Mary, I'm not a doctor, so I can't do diagnosis or treatment planning, but I've been working with Dr. Orent for 7 years now, and I can tell you exactly what he's going to say when he walks in the room, and then they would go into exactly what they wanted to say. So basically, they've given their disclaimer that they can't diagnose or treatment plan, so this is just one person's opinion, and the doctor's going to need to come in here and do the actual diagnosis and treatment, but this is it. Here's what happens. And I'm going to show you a little prop, which one of my favorite props, so don't go away. I'm back. Okay. I needed to grab a prop. This is a bobble-headed Dan Kennedy. Dan Kennedy is one of my mentors in business and in marketing. So this is Dan, the bobblehead. Now, why am I showing you the bobblehead? Because I have a theory. It's called the Bobble-Headed Dog, and all of my members know this. The Bobble-Headed Dog says that if the dentist walks into a treatment room, let's say it's a re-examination, the dentist walks into the exam room, and the hygienist, he or she has been working with the patient, let's say for half hour, 45 minutes, however long that is, and now it's time for the doc to come in. If it's an asymptomatic patient and the hygienist didn't go into, this is what I see, and not just diagnosis and treatment planning, but there's a piece missing there. Because Dan Kennedy, my mentor in marketing, would say, don't skip from problem to solution, which is diagnosis and treatment. You got to have a middle step in the sales process, or the sales process falls flat. And you know this as well as I do, that middle step is called agitate. So it's problem, agitate, solution. So again, the hygienist is looking at, okay, I see these 2 teeth are cracked. I can see that with this light. Patient has no symptoms, but the hygienist has found these with the transillumination. The hygienist has put in other diagnostics and found other things, and periodontal disease, which is asymptomatic. And so the hygienist goes into what we call preheating the patient, getting them ready, really emotionally charged to accept that treatment plan. When the doctor walks into the room, and by the way, in my practices, the hygienist would then give all this information to the doctor. It was on paper, but you can do it electronically as well, while the doctor is with their patient. And so before the doctor walks into the room, the doctor can take a quick peek at what did they talk about, what's up on the screen, what was the patient's reaction to it, how much have they covered. So when they walk in, the doctor can just be a bobble-headed dog and basically say, Mary, I'm glad that you brought that up. I am really concerned about that as well. And then they go into the treatment plan. It not only saves time, but it dramatically increases the case acceptance. Because, let me ask you this, Bill. What do you think a patient who's asymptomatic, who came in for a cleaning and checkup and thought everything was just fine, what do you think that the patient would think if the hygienist never mentioned anything? The hygienist was just cleaning the teeth and scaling and was happy and everything was great and they were talking about their vacations. And then the doctor walks in the room and says, oh my goodness, you need $5,000 worth of work just on those 3 teeth. What's the first gut reaction of every patient?
Oh, he needs the money. He wants the money.
Bang. And some of them even say it. We've all had patients who say, Bill, am I sending like 2 of your kids to college on this mouth? In fact, I have a short funny story and then I'll move on. My short funny story is, I had a member in Newport Beach, California, and we were talking about the theory of the bobble-headed dog, where the team member, and that's why when you said, the doctor is explaining all the treatment, I would far rather that the team does it before the doctor ever does. But anyway, so I had a member out in Newport Beach, California, and I was telling the doctor about this bobble-headed dog theory, that we should just be the second opinion, and then the patient really does appreciate that it's necessary more, because they don't perceive any money trail between a dental team member and the fact that it's going to cost a bunch of money. And certainly if the doctor walks in and says it when they're asymptomatic, they totally think it's money. So I said, I'm sure that patients have said to you, Doc, what am I funding your next Mercedes with this mouth? And he said, no, they don't say that. So I was taken aback because that was the first time. I've been doing this for 25 years or more, 30 years. I don't know how long. I can't even count that far back anymore. That's the first dentist who's ever said to me, none of my patients say, oh, do you need a new Mercedes? I said, how is that possible? I said, because every other dentist I've ever spoken to says, yeah, at least sometimes patients air what they're thinking, which is, you know, am I paying for your Mercedes? He said, no. He says, you don't understand, Doc. He says, Dr. Tom, he says, I'm in Newport Beach, California. He says, are you buying a bigger boat, Doc? So it wasn't a Mercedes in Newport Beach, it's just a bigger boat. I think there's still a place for the consult room. Here's what I would challenge the viewers to do. Here's what I would challenge you to do. Prepare your consult room so that it's, you know, it's our new normal friendly. So just as Han and Bill and his team are talking about, prepare the consult room so that you can use it just the way that it should be. And then run a little study on your own in your practices where you, let's say you do 50 patients by chairside and 50 patients in the consult room, and make sure that you don't do, it's an A-B split test. And it's not necessarily scientifically, but it's going to be good enough that you'll get a good feel for which works better for you. I would caution you, they should all be roughly the same size case. So you can't do A-B split tests where a bunch of the A's are 2 fillings and a crown, and a bunch of the B's are reconstruction and smile makeover. So they should be, let's say you're doing, you know, anywhere from 5 to 15,000, that's your range for this A-B split test, whatever. So you're roughly in the same ballpark price-wise. And I would also caution you, and this is really important, don't do your first 50 patients by chair and then the last 50 patients in the consult room. Because if you do AB, 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 then the economy, the local economy, things that are happening in the news, everything is roughly the same for them with the exception of the fact that they were in the chair and they're in the consult room. But look at the difference between a month ago and today as far as the economy goes, the world economy, the local economy. So in order to really have it's not going to be scientifically valid, but a valid enough test for you, doctor, the viewer doctors, for you to be able to determine, I kind of like Tom's idea of just leaving them in the chair and going, you know, talking to them about what they need. But I also kind of like the idea of the consult room because that gives a separate area where you're not in front of all the dental equipment. I don't know what to do. The answer is nobody can tell you which is better for you until you actually test this in your practice. And so I would do 100 patients, 50 AB, 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 and it's not going to be 50-50. You're going to come up with a 65 or 70%, maybe even 80% better in one or the other. And then, you know, that's where you want to do your consultations from this point forward.
Oh, fantastic.
All right. So, Bill, you're a dentist, so I got a question for you as a dentist. What are you personally doing to reduce the volume of aerosols generated in your practices?
Well, Tom, it's interesting that you say that because a lot of this presentation has been aimed at increasing air quality in the office. And I just looked at the CDC risk factor pyramid, and aerosols in dental offices are very high on that list because of the way this virus operates. And I hate to say it, but for years, only wore my glasses to see, right? And then we converted to scrubs and a mask. And now we're finding our masks don't work. So we've done extensive research into reducing aerosols. So that has been HVAC, that's been these standalone air filtration systems, it's been UV, and we've actually started to look at some things to stop it. And obviously there's some things that have been around for a while. We've got Isolite rubber dams, Mr. Thirsty, better PPE, all kinds of things like that. I had Han do this cool little picture for us. And I don't know, there's been a video that's been around for a while called If Saliva Were Red. And if you watch it, you're terrified. And one of the things you definitely want to reduce is aerosol in the operatory. So when you start looking at the design, which Han and Jim have done, this is a typical rear delivery chair with a typical size room. And if you look at it, one of the things you'll notice is we removed, there's cabinetry not in there anymore. You're reducing surfaces. So what we're trying to do is reduce the area that the aerosols are on. One of the new really cool things So you can see this patient has that, and these guys actually have the gas masks on and everything. Obviously, one of the other things we're doing is protect ourselves. I put this little diagram in here so I can remember how to take things off and put them on, because I haven't really had to think about that since I used to be a resident in the OR. But we found a couple of things, and this is one of them. And this particular device just became available, and it's an extraoral suctioning device. And it actually has quite a few studies. Have you seen this before, Tom?
I have not.
Okay, so this was developed in Asia when the SARS issue was coming up. And so it isn't like they just invented it 2 weeks ago. It's a very interesting device. It's one of Han's favorite things in gyms because it has HEPA filters, it has carbon filters, it has a UV light system that actually kills the virus and the bacteria. So you can place it close to the mouth, and if you just look at the picture, you can see how much it reduces aerosols. So what we believe is that between your HVAC and all these other things we've already talked about, that we can reduce the aerosols in the office to near really low, a quite low amount. There's Han and these guys, Jim, have a bunch of statistics. I don't have those statistics. But these are some of the things we're really working on. And Tom, that was why I asked you that question, because when you go back and look at this, do you want your financial person sitting around that area unless we're mitigating aerosols?
I'm glad you asked that question, because it wouldn't be my financial person. It would be the person who talked about the problems. It would be the assistant who's already in the room. For every dentist, the challenge is not to listen to what somebody says works, but to listen to what somebody says works for them, and then to test it in your own practice, because what worked for me in my practices or Bill in his practices may not be the best for you. Having said that, I've worked with thousands of dentists over the last 26 years, and I can tell you that walking them out and doing a separate consultation in another room with a different person, bringing in other people, then there's the handoff or the passing off of the power and all that. You're losing patients, you're losing treatment, you're losing dollars, and you're not helping the patients. Now, there may be practices where that is the absolutely best way to do it, because maybe the person who you're passing them or handing them off to is amazing, in which case you'll absolutely want to do that. That's why I say there is no one right answer. We each have to try many different things and see what works best for us. Bill, let me ask you, how do you see disinfection, also sterilization protocols being affected by all the changes that are happening right now? So what are you currently implementing, and also what are your plans for the future?
So what we've done is I brought Mark Bly along, who has actually done a lot of research into FDA and EPA products to be used in the dental office, and some changes that we are making. So Mark, could you talk about that a little bit, please?
Thanks, guys. Yeah, the protocols and the disinfectants, both procedure and product, is certainly going to change because of this. The alcohol-based sanitizers that have been used in a dental office, it has worked in the past, but some of the new technology is going beyond the alcohol kill and using what's called a molecular bond, which actually from a particle charge standpoint kills things. Simply, the advantage of it is these bonds that get formed can kill germs up to 24 hours, whereas your alcohol-based sanitizers and things that are currently favorable to be used in an office last as long as the product is wet.
So, and didn't we look at, I know you were looking at how cavicide affects dental equipment?
Yeah, that's one of the other things. Every dentist out there knows that alcohol kills. It kills a lot of things. Germs, rubber hoses, O-rings, leather material, things that are costly to replace. So the advantages of some of these new technologies, and they're proven, is that it's not an alcohol-based product. One in particular is a product called Germ-Free 24, which uses a product called Zitrocell. And Zitrocel's been around a long time, but it uses that molecular bond in a partically charged environment to kill the germs instead of using alcohol. And the side effect in that regard is it doesn't eat leather or hoses or O-rings or things in that line. It also doesn't eat your employees' hands or your hands as as a practicing person in the area. So
Let's let's actually take a slightly different approach here. You've got practices who pre-COVID-19 may have been either in a design phase or they had just started construction, and it's got to be really difficult realizing that everything has changed. And so what would be your recommendations now for offices that had started either design phase or maybe even under construction? What do they do?
Well, I'm going to punt this to Jim, our architect, Tom. He's actually done a lot of looking at this very moment, actually. So, Jim, what would you suggest?
Well, absolutely. You have a situation that you're creating something that you effectively can't even open and be protected. So you're going to have to reevaluate. You're going to have to reevaluate all your strategies. You're going to have to reevaluate where you're at. So you're going to have to pause, no matter where you're at, and do that reevaluation. So you might be under construction. You might be in a scenario where you've still got walls and stuff that haven't been built. Now's the time to implement. You may have to upsize your equipment. You may have to upsize your HVAC equipment or put
And what
other
are three
systems.
things that we already changed in this picture?
The three things, this is your particular edition that's in there, and the three things we've already changed was we've upsized your equipment. Thank God it wasn't ordered. And also
That's HVAC, right, Jim?
Yeah, we're putting in UV light, and we're also in two locations. We're putting in both for surface and also for air. And we're also going to be implementing the standalone air filtration. And being able to upgrade your equipment has allowed us to increase your air changes. We're effectively creating this space as a negative air pressure. So we're exhausting more air than we put in. So any pathogen that's in that space or that part of the building will stay there and then get exhausted. So it's not going to migrate into the rest of your building.
Now we've actually changed the cabinetry and the flooring too.
That's true. That's a
Great
given.
time to do it because it's not
Yeah.
built, it's not installed.
Yeah, thankfully. But again, you have to evaluate where you're at, not knowing each person's going to be different.
Bill, if doctors are interested in your consultation services, what's the best way that they could contact HJT?
Well, the best way is they can look at all this stuff. This is some of the programs we have going right now. But the very best way to get a hold of us right now is to go to our website and or pick up the phone. There's a way to directly get our phone numbers and get into our schedules. But that phone number will ring and we will answer it and we can help you. Like I said, we're offering a free consultation, a free look to see at what your issues are.
Appreciate that. And I'll tell you that I have learned so much speaking with you before the program and looking at all the literature that you sent and your team there of the various experts that you put together. It's really appropriate for today's time, and I really appreciate not just you but the whole team, all of you guys, for investing your time to share with our viewers today.
Thank you, Tom.
Thank you,
Thank
Tom.
you all.
Thank you.
Thank you, and be safe out there. Stay healthy, and again, thanks for what you're doing.
Thank
as
you.
well.
You as well.
Take care.
If you've enjoyed this, subscribe to the channel and hit the bell notification so you won't miss a thing. If you're not yet a GEMS family member, Elizabeth and I would be delighted to help you build your practice and your revenue. We'd love to have you with us here on Planet GEMS for a limited time offer. A free test drive of GEMS membership. DentalGoldmine.com. There's a link in the description below. If this was helpful, please click like, and I'd really appreciate if you could share this with other dentists. Thanks for joining us here on the Dental Goldmine, and remember, you're only one gem away.